Good morning, or I think almost good afternoon, still good morning. Welcome, everyone. I'm Kate Warren, Executive Vice President, Executive Editor at Devex, and delighted to welcome you to this session in partnership with the Saudi Commission for Health Specialties on a topic that I think pretty much every discussion at WHA comes back to, and that is a shortage of healthcare workers globally. It's so critical, the backbone of our health systems. It's a challenge every country across the world faces. So we will be digging into that today. There's projected shortfall of 11 million healthcare workers by 2030. And that's not just a statistic. That is a crisis in the making and really contributing to all of the health challenges that we're tackling this week at WHA. So I'm really delighted to be able to have this conversation today. And I'd love to welcome to the stage Dr. Dina Al-Ismail, who is Executive Director of Health Diplomacy at the Saudi Commission for Health Specialties. Join me. Thank you. So Dina, I'd love for you to kind of set the stage for why this is such an important issue for you, particularly this week at WHA.
Well, good afternoon, everyone. Well, workforce is the heart of the healthcare system. With the workforce, we will not be able to survive. It will collapse. So this has been in the dialogue and all of our dialogues this week since we've arrived to Geneva. So we're very pleased to have this opportunity to speak with our global colleagues and health advocates who are, they speak the same language, and to align together and to forecast how can we fix this situation before it becomes a crisis for us.
Great. So, I would love to start talking about some of the challenges, right? And we mentioned projected shortfall of 11 million healthcare workers by 2030. And it's particularly a challenge hitting low and middle income countries. Again, this is global, but particularly a challenge there. And health systems are increasingly under more shocks, be it from climate and crises, economic shocks, other public health threats. So what do you see as the biggest obstacles in developing a more robust global health workforce, and even particularly how credentialing, which is what we're going to really dig into today, plays a role in that?
Okay. It's an interesting question to tackle, but as you mentioned in the beginning, we're projecting 11 million shortfall in our workforce. And as you mentioned, it's not just a workforce issue, it's a healthcare system crisis that we need to handle. If we tackle it in three areas, probably the first one will be what we've been seeing is the mismatch between education and the skill set needed for the practice. This could be one. The second one is the fragmentation of the credentialing system. And thirdly is the lack of innovative processes or tools for workforce planning. So if we talk about the first one, is the mismatch between the education outputs and the clinical practice. We've seen that too many often that a lot of the graduates, they might be on paper competent, and then they get credentialed. But when they enter the workforce, there's a lag in their knowledge and their expertise and their the skill set that they need to practice. So what we've been doing in the Saudi Commission for Health Specialties is that we've been working on competency-based education, competency-based assessments to help at least bridge that gap that we see in this mismatch. And we've been trying to work with all of the professions under our umbrella to help build those education systems with a competency framework. The second element is the fragmentation of the credentialing system. And we could see this fragmentation across borders. It has been a challenge, and for the past while, we've been working on harmonizing our credentialing frameworks, where we'll have healthcare providers that won't be restricting their mobility, that are ready for any crises and emergencies. So through mutual recognition and harmonizing credentialing processes, this will truly help at least ease that pain. Thirdly is the lack of tools and planning. We've utilized for many years and relied a lot on static data. There is supply-based planning. And we've been working in the Saudi Commission on thinking differently, finding innovative ways, innovative tools to help us have dynamic workforce intelligence, intelligence that is AI-driven, AI forecasting, that help us prepare for the future and prepare a workforce that is future-ready.
I want to dig into that harmonizing the credentialing challenge that you laid out. And there's different processes and education models and the regulations around it. What are some of the challenges to that harmonization, and maybe some examples of ways you've been able to overcome them?
So harmonization is, let us not mistake it with standardization. And I think a lot of people are, when they hear let's harmonize credentials, they feel that we're stepping on their territory, you're stepping on their turf. So harmonization is alignment and agreeing on the basics. So it could be agreeing on the foundational core competencies for professions, agreeing and aligning on ethical practices, building that trust with different countries where we can align. We have a mutual recognition of our credentials. And this is a bit challenging because everybody is protective of their knowledge. So probably building trust is very important. Leveraging what is already available from trusted bodies like the WHO. They have their global code for practice. So we can agree on this. This will be the foundation for us where to work from. Improving and fostering transparency of how we do our credentialing, how we do our assessments, how we do our processes, how do we measure, share knowledge, share experiences, also will help in building those opportunities. And finally, probably sharing a common competency framework that helps us speak the same language across borders.
And so you mentioned the skills gaps that there are and some of the challenges in making sure that people are credentialed, they do have the skills needed. And healthcare is a really fast-changing space. You mentioned AI, and AI is now being integrated in a lot. So how do you think about the role of regulatory bodies and being able to properly skill healthcare workers and acknowledging that it is this dynamic, fast-changing space and profession?
So regulatory bodies are the guardians of professional practice. Very protective, very strict. However, we need to understand that regulatory bodies need to enable innovation, be enablers of the healthcare practice. They need to support the evolving competencies, how work is done, because we cannot be rigid, we cannot be strict, because we know how regulations sometimes take a lot of time to be approved and to be accredited and to be stabilized. So a lot of people are they hold on to it. So we need to know that the world is changing around us. We need to be agile with that change. us at Saudi Commission, we are a regulatory body, but we've been trying to work on enabling innovation and being an enabler for the professional practices. We've been building our competency frameworks. We've been doing a lot of education and training reforms where we're embedding competency-based learning, interprofessional training, simulation-based training, looking into different modalities, how we can be more innovative and utilizing many of the tools that are available to help improve the practices all over.
And what are you hoping to see happen either within official or unofficial conversations here this week at WHA around being able to really mobilize more action around this healthcare shortage and building a robust healthcare worker system?
I think creating international collaborations, speaking the same dialogue about harmonizing mutual credentialing, how can we leverage the knowledge and the expertise from each other, where we can share knowledge, explore different innovative practices in worldwide. I know there's a lot been done globally, and this is the forum that we can share that knowledge and share that expertise and learn from one another. We don't want to reinvent the wheel. We want to learn, and we're open to learning from one another and exploring that.
Well, Dina, thank you so much. And we will continue the conversation. I will pass it over to my colleague, Devex Global Health Correspondent, Andrew Green. And we will continue to explore ways to build a very mobile, credentialed workforce. But thank you, Dina.
Hi, so my name is Andrew Green. I'm a global health correspondent with Devex. And I think that session was incredibly helpful in both framing the problem around the shortage of health and care workers in the world, but also starting to turn toward looking at potential solutions to this problem. And so I'm excited to be joined by 4 experts for the next panel who can share some more strategies, solutions to the shortfall that we're facing. As I introduce you, I'd please come up to the stage and take whatever seat you'd like. So I'm lucky to be joined by Jim Campbell, who's the Director for Health Workforce at WHO. Dr. Ottmar Kloiber is the Secretary General of the World Medical Association. Leslie Mancuso, the President and CEO of JPIGO. And Dr. Joya Mukherjee from Harvard Medical School and Partners in Health. So we'll just dive right in. Jim, I'll turn to you first. I know that the WHO has long been concerned about the global shortfall of health and care workers that's approaching by 2030. So what can countries do to address this and specifically ensure that these workers are well qualified and trained for the positions?
So good morning. Thank you very much to the Saudi Commission for Health Specialties, Devex, for a necessary conversation on this issue. Absolutely. The resolution and the agenda items will likely Thursday or Friday in the Assembly. What are ministers and their delegations talking about? Solutions. We've described the problem so many times over the last 20 years. Solutions, action, partnership. But let me just, Andrew, if I may, a couple of points. When we talk about shortfall, we just should stop and think about it. It's not singular. There's not one shortfall. The shortfall the WHO talks about is the universal health coverage shortfall worldwide. But that doesn't count the high-income country shortfall. That doesn't count the public health shortfall, emergency preparedness shortfall, One Health, climate capacity shortfall. Doesn't show the shortfall in distribution, inequity. So there's many elements of shortfall that we should really, really be looking at. And I'd like to challenge us to think about this in a slightly different way, because let's just look at the shortfall in the high-income countries. And this is why I thank again Saudi, because they're being quite brave here to put on a discussion around migration, mobility, credentialing, because there are 10 countries, high-income countries in the world, which have domestic shortfalls. And yet, they're not educating enough themselves. So let's just look at the numbers. 10 high-income countries responsible for 2/3 of the world's global migration, coming from all those low and middle income countries that don't have enough, the 11 million shortfall. We have 1.3 million doctors and nurses in those 10 countries from the global south, worldwide. And how much? What's the subsidy? Everyone's talking about Donald Trump and the cuts to official development assistance. I'm sure your American Devex colleagues. And we're talking around what, 20 billion or 10 billion, depending which numbers you look at, reduction in official development assistance for health. Let's just count the subsidy in education. We're talking in the magnitude of $270 billion in education in low and middle income countries, subsidized through migration movement. If we fixed education in the 10 high-income countries, if we actually invested in education, we would certainly have a major counterbalancing effect on the 11 million shortfall in low and middle income countries. Just numbers. Just think about it like different. It's not the only solution, because we support twinning and partnerships. We support education exchanges. We want this multilateralism. We want people crossing borders and interacting. We don't want to lock borders. We don't want to build walls. We don't want to build, blocks. We want a multilateral world. So we fully support mobility. But let's look at the behavior of the high-income countries not investing in their own education systems as one of the solutions. Thank you.
Thank you. And Dr. Mukherjee, I'd like to turn to you next. Your Partners in Health does a lot of work in these low and middle income countries that we're just discussing. In those contexts, are you seeing strategies or solutions that are working that permit mobility, but also still help retain the necessary care and workforce?
Yeah, I think thanks so much for this panel, and thanks to the Saudi administration for putting this on. It is really important. It is important for us to think, I'm from the United States, a high income country. I see that brain drain happening. I think our approach at Partners in Health, one, is working with governments, so it's not just a parallel system. And second is really to have place-based education. And I have to say, my medical school in the United States, the University of Minnesota, did this. I learned this at University of Minnesota. It's a public school. And the state said, if you don't turn out some docs for rural Minnesota, we're cutting your funding off. And what they started doing is sending students to rural areas. And often, not always, but often, I'm a failure of that system, but often they would fall in love with that and stay. And we have tried to do work like that at Partners in Health, where we have rural hospitals that are busy, because they have the appropriate, staff, supply chain space, systems, the work environment is good, but they're in rural areas with adequate mentoring, adequate support. And we train physicians and nurses and biotechnicians and others in these rural environments and give people the right support. And it's really surprising how many people will choose to stay. So, for example, we've been doing residency programs now since 2010 in Haiti. This is year 15. And even with the current crisis, the large majority of our residents trained in surgery, OBGYN, family medicine, emergency medicine, et cetera, have stayed. And before the current political crisis, it was about 90% of our residents stayed in Haiti. Now it's a bit lower, down to in the sort of high 70s, but that's not because of the work environment. That's because of the larger political environment. So why do people stay? They stay because they have the tools they need of the trade, because the compensation is reasonable. It's not sky high. They could make more going to the United States for sure, but it's reasonable, it's fair, but they have the tools they need and the mentorship. I think often what you see in resource limited settings is people are in these wards without the right tools, without medicines, without adequate supervision, and nobody wants to work like that. So I think if we could think about how do we make hospitals, regular district hospitals, into teaching hospitals, right? And that would give people a much more interesting, stimulating environment. But then we have to resource it. And of course, the elephant in the room is the cuts to foreign aid. And so in Rwanda, we started a university with the government of Rwanda. It's a private university, but the teaching hospitals are public hospitals. And it's in rural Rwanda, and we try to select students that are from rural areas, and they have to sign a bond for 6 years to work for the public sector. But it's also trying to create an environment that people are choosing to work there. So I think it can work in the US. I think it can work, in resource limited settings, but it does take some money, and it takes a lot of investment of mentors, people who are willing to be side by side with the trainees, whether they're nurses or laboratory technicians, because so often people are really on their own. And I think that is one of the many reasons people just give up.
Dr. Kloiber, I'm curious from your perspective with the World Medical Association, what strategies you're seeing, in all of the many different countries you're working in. You told me more than 100. What is working in terms of training and retaining health workforce?
There is a very simple answer to that. A good, well-functioning healthcare system. Most of my colleagues, most of the physicians, and I'm speaking here in first place for the physicians, but I know from my colleagues in the other health professions, in our World Health Professional Alliance, things are pretty similar. People would like to stay locally. They would like to stay with their people. There is not necessarily an intrinsic move outwards in the country. There are for some which are academically interested, want to see something different in a different country, learn somewhere else. But the first rule is they want to stay where their people are, where their language is spoken, where the culture is, where the food is the same which they have, and where they can raise their families. And since World Health Report, I think I see three major factors which are true for the question of retention, and that is true for rich and poor societies. And that is number one, yes, you need to have a fair remuneration, but equally to that comes you have to have working conditions that are worthwhile. That you have to have an ability to treat your patients, to have the medicines to be there, to have a ward that is clean, to have running water in your hospital, in your practice, that you can go there in the morning and you can do something good. And not only those siloed programs which are out in this world for tuberculosis and HIV/AIDS and so on. Unfortunately, the people in poor countries also break their legs, have heart infarcts, and they're nasty, these. So we have to have healthcare systems which really offer something comprehensive. I commend the idea of the universal health coverage by WHO. This is the most important thing there. Second, to have a career development. You must have a chance to develop in a country, have a life course in your personal and professional development. And that includes working conditions which are worthwhile to be there, especially also, and very important nowadays, more than ever, to be free of violence, something that doesn't happen anymore and is not as natural as it should be. And third is your environment, your living conditions there. Doctors, nurses have families, and they want to stay in a safe and life-worthy environment. And we're not talking about luxury features here. We're talking about the normal things, like having a perspective for your kids to go to school and to be safe, not to be in a war zone. So and these factors are the same for, and that is what we found out, and we found it out together with WHO and separately from it. That is true for rich countries and for poor countries. Now, the nuances are very different. The situation is much harder in many of the poor countries, and that is clearly and very easy to be seen, and therefore the push factors to go out of those systems are much harder. But then what we also see in the rich countries is, we have, for instance, a tendency in many of the European countries that doctors whom we sometimes had to carry out of their practices when they were 75, 85, and said, it's enough now. Nowadays, they come in with 60 and 62 and say, can I go into early retirement? I'm sick and tired of this bureaucracy and of these healthcare systems which handcuffs me and I cannot work for my patients. So even with a very good material situation, you find this problems coming up. And considering the density of physicians, for instance, here in Europe, being nearly 100-fold from what it is in the poor parts of Europe, a change here which pushes physicians out of their job, going into different positions, or just going to half time if they don't want to work full time anymore, means you are producing a huge shortfall, which equals nearly the whole workforce what you have in Africa. So we have to be extremely careful of those social movements, not only the spatial movements, also the social movements within the society. To that extent, I completely agree with what Jim has said. Rich countries are not doing enough for education, not doing enough for retention, but let's be fair, the poor countries are not doing that either. We have enough countries in this world which take their money to have a nice war with their neighbors, or if the neighbors are not available, with their own poor people, instead of investing this in the development of their societies and investing this in healthcare. And this has to change. Universal health coverage is the way to go.
Thank you very much. Leslie, I was talking to you beforehand. I'm very familiar with Japaigo's work. I've seen it on the ground in places like Uganda. I'm curious, I know you do a lot of training of health workforce. What's been successful? What's working?
Well, first, thank you to the Saudi Commission for putting this on. All topics very important. I also want to congratulate you on the State of the World's Nursing Report. For those of you that haven't seen it, it's a very important document that lays out some of what's happening to the nursing community. And as a nurse, I know you spoke for physicians. I just wanted to make sure that as a nurse, I spoke to the importance of all these factors fit for nursing as well. So, there's all commonalities, as you said. But let's talk a minute about, looking at a credentialing and sustainability. I think the question was about sustainability. There's no doubt that you need a number of factors to have sustainability around the credentialing of a country. And certainly you have to have the leadership, the national commitment, and you have to work through and with the structures that exist in that organization, in that country. So the organizations that are responsible for this. So I'm going to give you an example of Ethiopia. We just completed a multi-year program in Ethiopia, an HRH program. And in that program, we worked with the government and worked with many different bodies, and I'll go through that in a second. But the most important thing was to look at this whole, how you look at establishing credentialing standards for, we did it for 11 health professions in the country of Ethiopia. Now understand that showed commitment in and of itself by that country, by that government, and by those that are committed to the topic of making sure our workforce has standards of practice and has regulation. And so we worked with those 11 professions, and quite honestly, what has happened and what we did was we not only worked with the government and the Ministry of Health, but we worked with the Ministry of Labor and the Ministry of Finance. So you must work with all components of the government in order to get these kinds of credentialing standards to be consistent and to be accepted. Now, when you go in to assess, to get sustainability, you first have to assess what you're working on and what your issue is. so to get that, we had to look at were there regulatory bodies within Ethiopia for each of those professions, and or what was the education system? And then based on that, worked with the organizations that existed within the country. Most often, we need to strengthen those organizations. And so there was a very large strengthening component, but there was also a co-creation, a building of, and making sure these credentials and these standards of practice for all 11 professions were done. Now, we've left, but this process and everything is continuing. It's being led by the government. It's being led by their organization. It has I think it has a name, training, and I think I kept it down here, Education and Training Institute. And so they are carrying this on. This is sustainable, but again, you're working within the structures, with the leadership, with all components within the government that will influence these credentialing standards. And so I would say in closing that what's really important is what I started with. You have to have that leadership. You have to look at the processes within that country with the country. Everything has to be driven by the country. And you have to be able to get everyone to own this. It's their work. It's not our work. It's not Chipago's work. It's their work. And they've now created that system for standards of practice and accreditation.
I think you'd like to respond.
Yeah, just on a couple of points there. I mean, obviously, Leslie, we've worked with for many, many, many years. And indeed, thank you. The State of the World's Nursing, it's a worldwide contribution. It's fantastic. Launched last week on International Nurses Day, and will be official side event in the Assembly momentarily on the report and the findings. And part of the solutions in that report talks to exactly what we were having here in terms of that regulatory framework. And we've just published, member states expert group looked at the regulation of health professions worldwide, Andrew, and what are the opportunities? And it's a phenomenal piece of work looking at sort of where are we seeing the opportunity from regulation of the health professions, regulation of scope of practice, accreditation of education institutions, the role of medical councils, nursing councils, sort of and the fascinating, the Agya's in the audience, Dr. Agya Mahat led this work. The fascinating thing I found, even after 25 years in this industry, the thing I found most exciting is the potential of regulation to support public policy priorities in addition to patient safety. We've all, fitness to practice has been there for decades and decades and decades, but this opportunity to influence behavioral change and the market conditions. And so we're seeing that opportunity, and with the Saudi Commission and then the colleagues there, we're saying, okay, well, how can we go a little bit further now? We've got an excellent evidence base of things. How can we get practice? How can we turn this guidance into practice activity in more and more countries to address the practice gap? And then another piece, which we'll talk about this evening in the official event on the colleagues are hosting. How do we look at credentialing of lifelong learning? How do we look at the behavior of not undergrad and postgraduate, but all this informal learning? And so we're working with the professional associations, with UNESCO, the education specialist, with ILO, the labor specialist, to look at how do we improve quality through credentialing for this discussion, workforce development, workforce mobility. If I'm a physician who's gone and done a program in antimicrobial resistance, what do you have today? A piece of paper, a certificate. You participated in a 2-hour program. Then you want to go and work in Saudi or the United Arab Emirates. What value does that little piece of paper have? Minimal. So how do we get into standards of quality and practice so that I can actually assess, this nurse is an advanced practitioner with all these additional skills and competencies, which I value to work across in these opportunities.
I think we've got many people who want to respond. Let's go down the line.
Yeah, I just want to kind of query for all of us the the notion of sustainability for some of the poorest countries, because I think we still are stuck with a very limited wage bill. And so there are many countries that would like very much to hire. I work in Malawi where they cannot hire all of the professionals that they train. So it's hard to talk about sustainability. These wage bills are externally imposed. These are not decisions that are made within the country. And I think as we think about how people are going to remunerate, retain, and not even, some countries are making bilateral agreements to send their workers, famously Philippines, but many others as well, for remittances. This is, unless we can tackle that problem of the wage bill, it's very, very challenging. And, I work a lot now in West Africa as well, in Liberia and Sierra Leone. The majority of the public sector staff are volunteers. They're not paid at all. They show up to work and try to maybe charge the patients at the bedside for this or that. So there is this public sector spending cap that we still are going to have to deal with, no matter how big the pipeline is. So we need a lot of people to put their brains together, and maybe in this, what I'm calling Global Health 3.0, what does it look like without the massive influence of the United States? Maybe there's some new flexibilities we can explore.
Yeah, I think that's interesting. This does kind of give us new opportunities for rethinking the old systems. Dr. Klober, I think you wanted to respond to the...
May I respond to it? At least for the physician side, I can report what we have is the World Federation for Medical Education, to which we are part of, to which the International Students Association is part of, WHO is part of, medical faculties from around the world are part of. They have started years ago, now for more than a decade, to come up with a program of recognition of accreditation. And this is something that becomes a standard for credentialing, whether you are coming from a school that is accredited or not, and that this accreditation is actually valid, which means that the accreditation follows some quality standards. And that has been a very successful move with the medical schools, because there are now many medical schools which have signed up to accreditation, and there are accreditation agencies which are now being recognized because they follow certain quality standards. Standards set by the World Federation for Medical Education as well for the education part, but also for the standardization of the accreditation. And this year is being rolled out into postgraduate medical education, which is a field which is even more heterogeneous in this world. Even between the rich countries, it's very, very different how postgraduate medical education is structured. And in a third column, to the CPD, the continuing professional development, which means lifelong learning, that I think is actually even more important as we go on with the rapid change in our professional profiles and the work we're doing and how we do work. The specialization, I think, will become a little bit less important, and the CPD, the continuing professional development, will become more important. Now, this has been rolled out. Next week is the World Conference for Medical Education being held in Bangkok. These programs will be officially introduced and started. And I think that makes a change. Takes some time, takes some years in order to sign up for countries and organizations for that. But I think at that point, at least we can tell this very clearly for the undergraduate medical education, it makes a difference.
Yeah, that's really promising progress.
Can I just add one thing? I don't know if any of us have said this, but the other challenge in these countries is the whole notion of the deployment and where these health workers are positioned. It's not always apparent. And, there needs to be as well, new plans working with countries around a data system, a digitalized system that allows them to know who they have, what they have, and where they're needed within that country. And I think that's certainly there are some countries that have it, but there's a lot of countries that know they need it, and we need to give them that assistance.
And on that note, I was wondering if you could talk a bit more about, you talked about your integration working closely with the Ethiopian health system. Are there other lessons that you have from advancing global priorities, but thinking about it in a local context?
Well, there's no doubt that we've spent a lot of time with nursing and midwifery councils over the years. A very important aspect in these countries is to support these councils that support the nurses and midwives. And so, you know, again, it goes back to, I keep using co-creation, but really the creators are the countries. And if we must give them that authority, and we are simply there to guide. So sometimes when we all use co-creation, it becomes really you creating and them saying, okay. But I really want it to be us helping them create. So in a lot of these countries, and we've been, like I said, in 20 countries alone, we've worked with nursing and midwifery councils to build these councils up, to make sure that they have the capacity to regulate, the capacity to even know who their nurses are, and where they're working and what they need. They've been a rich resource, but they need support and they need to be developed. And we've worked with them quite a bit. And we can work not only on the public side, but we've worked on the private side, you know, where we've had to look at private credentialing and trying to help, like in India, them meet the needs within a private system of the credentialing standards. So, you know, I think again, it's working with them, it's working to support them, it's letting the country, again, I go back to, you have to have the national commitment, you have to have the ministry's commitment, it has to be theirs, and you have to look, you know, the first thing we should be doing when we go to countries is look at their priorities. What are their priorities? And what are their policies? We need to understand what they've laid out in order to be able to work within that system so that we can help them create what works for their country.
That's fantastic.
Andrew, if I can, Leslie, again, you're giving us all the right leads here. You know, all the ODA cuts that we're hearing from, everyone in the room is aware of these. And it's not only America. There are many countries, part of the Development Assistance Committee, cutting aid to spend money on ammunition, war, the rest of the conflict. So let's just look at the opportunity there. We've got to be more efficient as a group of actors and stakeholders. We have to put the country first and foremost. And UN agencies, non-governmental organizations, civil society, health professionals, the rest of us have to eliminate duplication. That has to be one of the solutions that we actually agree to as a result of this World Health Assembly. Eliminate duplication, overlap, competition. Let's come back to core partnership in support of this. We shouldn't, public data on the workforce, if we're talking about workforce development, who are they? Where are they? What education, what competencies, how much does it cost? The national information, the national health workforce account. No more surveys, no more, you know, I want to extract data for my project. Help the government measure the workforce. Help the government determine its policy and then support them to implement. That must be something from this World Health Assembly, please.
I agree.
Well, I think this has been a really rich discussion with a lot of both examples raised that show how this can work and also questions about what the future is going to look like. We have about 15 minutes for audience question and answers, so I'd love if anyone has anything they'd like to ask the panelists, please just raise your hand and someone will bring a microphone to you. We have a bunch. Maybe I saw your hand first over here in the corner.
Hi, I'm Dr. Shalyanan. I'm a dental surgeon from India. Okay. Hi, I'm the chair of the Oral Health Literacy Group of the International Health Literacy Association. So the question I want to ask you is a very personal, from a personal experience. I practiced dentistry for 26 years before I did 2 masters and moved to Netherlands. I have the knowledge. I have so much that I can give to the country, but the credentials can go with the talent. But what about the language barriers? So that's something that I would like to ask you. How do we do that?
Thank you. I'll take 2 or 3 questions to start. I think you also had your hand raised.
Thank you for a very inspiring conversation. I'm Adeze Ore from Nigeria. I was Commissioner for Health in one of the states in Nigeria just until about a month ago. My question is, and I was happy to hear about security as one of the push factors that send people migrating out of their home countries. So when you interact and engage with some of the countries, how much of the conversation is around the factor of insecurity? Because I find that in Nigeria, when we had the conversations around health worker migration, we somehow seem to sidestep that very critical issue. And you rightly said people don't always want to leave. They want to stay with family. They want to stay with aging parents as well. And so how much of that conversation around insecurity has featured in the discussions about migrating and borderless health workforce? Thank you.
Thank you very much. We'll take one more question. Gentleman in the front.
Thanks. It's been really an inspiring session. Omokudu Idogo is my name. I'm the Managing Director for the Society for Family Health in Nigeria. My questions really is around the concept of the borderless health workforce and what are the possibility around looking at comparative competencies across the world to say clearly some geographies have more in terms of population, in terms of desire, and even cost of production. And therefore a conversation around, can we actually have some sort of global remit to say, let's produce more where the cost is lower, where the interests are, and then let it serve a bit of like a global market. So the very idea of it being borderless, that would be my question.
Fantastic question. Thank you. I guess I'd start, anyone would like to address the language question to begin with, if that's something that you're cool with?
I must admit I have not really understood the language question. To me, there are two different aspects of seeing that. That is a patient who speaks a different language, and there is the problem of a doctor who speaks a different language coming into another country with that. The second one is usually to be remedied by requesting to learn the language of the country, and that is usually being done in most migrating accepting systems, that you have a language test as part of it. This has to be done in a relative way. There's certainly a different requirement for having language competency when you are being a laboratory physician and working away from patients, or if you are somebody who is delivering primary care or psychiatric care, where you need a very high language competency in order to converse with that. It gets more, with our migrating world, it gets more complicated when it comes to patients speaking a different language in a country. And there is actually a demand for a higher investment from our healthcare systems in order to enable people to speak securely and privately with physicians and nurses. And that is a challenge because very often we rely on a family member to translate, which is actually not ideal for many things. Sometimes that works. In most cases, it doesn't really is a good solution. And yes, when we accept migration or have to accept migration into our countries, into the diverse countries, we have to think about facilitating the interpretation and translation in those systems as well. Some countries are better in doing this. The United States, for instance, is a country which very often has already these services installed. In Europe, we are pretty slow with that, and we still have to learn with that.
Yeah, I mean, I would just say that in the United States, that was a series of lawsuits that were brought by patients that forced that, which I think was fantastic. I just do want to say something about security. I think it's a major issue, and it's also a very gendered issue. So when you have the workforce that is predominantly women, where you have a lot of especially nurses, but increasingly physicians and other, it's often the women who cannot stay because their children are somewhere else. They're putting their children in a safer environment. So I think we have to think about the whole, as you mentioned, what is the life for the family? And I think that it is hard for people to make a longitudinal commitment when they're separated from their families. That is worsened in settings of security. So what can we do about that? I mean, that there's no easy solution, but certainly providing safe housing, certainly providing schools that are nearby. There are things that we can, fight for to kind of build more of a community around facilities. I mean, service jobs are still the biggest jobs, right? And so if communities can grow up around those, it can give us a little more security. But in some places, like I'm sure in Nigeria, in Haiti, it's not safe for anyone, and certainly not for women, who are the majority of the workforce.
I think everyone wanted to tackle the security question. Would you like to go first, and then we?
I just want to, security and the issue and the whole issue of movement and migration and exactly that. You've got to disaggregate this because security in different occupations for men and women is a different issue often. And even as we go down into community health occupations, people without clinical authority who are then in a whole different situation, and whether that's vaccines or communicable disease programs or nutrition, etc. Again, security, a major factor. But just into this migration issue is dominating the week. We've had a whole series of conversations this morning with the Commonwealth. There's a discussion this evening on bilateral labor agreements, which the global health partnerships are hosting with member states, the code this week. Just draw your attention to the document at the World Health Assembly, your idea, what's the alternative? Can we do better? And yes, there are proposals for discussion this week. An expert advisory group, member states have come together, looked at this issue. There is an alternative. The numbers I gave momentarily, this education subsidy that's happening today, 270 billion in only 10 countries. So how do we look at co-investment? How do we look at that opportunity? How do we help the Philippines nurses? The Philippines have been producing nurses for years and years and years around the world. Can we not help the Philippines to faculty development, institutional capacity, quality, accreditation, exam, make sure that the dropout rate in Filipino nursing schools is very, very high. How do we improve that so that they can be the workforce of the world in nursing with their... Let's co-invest. Let's not just take and not subsidize. Let's co-invest in that capacity. Africa, the greatest population growth in the world, young population, all looking for jobs. Let's co-invest. Yeah, Saudi Arabia needs workers. United Arab Emirates, here in Switzerland, foreign-born, foreign-trained nurses, doctors, they need workers. Let's co-invest in a global workforce with the competencies, credentials necessary to be able to move, but with protection. With protection. Guarantee of decent work, guarantee to work to license. We don't want nurses working as care workers in Europe. No, thank you. That's right. Yeah, absolutely not. To license, to scope. Thank you.
Well, it's always hard to go. It's always hard to go last because Jim, you could tell we've worked together a long time because what I was going to say, you said a lot of it. Actually, I think your comments were equally. Let's set the stage. Where many of these women are working are way out in communities. They are by themselves. They are young. They have limited support. I'm not saying this as a negative. I'm saying it as a negative, but I'm saying we need to understand about this. We've even looked at insecurity in schools. It's oftentimes starting in pre-service education, where we've interviewed women in the nursing schools and have learned that that exists even during nursing school. And so, we've got to look at this issue and realize that it's been an issue. It's been in the nursing report. It needs to be addressed because that is one reason they are leaving. And if they don't want to leave, we want them to be safe. We want all women, particularly nurses, to be safe. So.
Well, let me put some water into the wine here. This is not a nursing issue isolated, not at all.
No,
not at all. The numbers speak completely against it. That is across the border, and I think one of the questions came from India. There, if you go to YouTube and look on videos, you get days of videos where there are violent incidents on physicians, female and non-female.
That's true.
And so this is across the border. So don't focus this on one section there. That's would be incorrect. Our governments have to make sure that those who help, that those are in healthcare, are being protected, and our governments are not doing enough on that. Not at all. Not in the rich countries, not in the poor countries. And in some of the poor countries, they are actually doing the exact opposite. They're putting them at danger. So I think there is a big challenge that is out, and there is no rosa flag to it. It is a black flag and a red one. Thank you.
Thank you. So we have 2 minutes left, and in that time, rather than try to take more questions, I'll give each of the speakers about 30 seconds for any wrap-up comments you'd like to make, anything you didn't get a chance to say.
Want me to start? You know, I've said this week in a couple of speeches, but you know, this is our time. There's been a lot of changes. There's been a lot of data. There's been a lot of research on this. We've talked about it. But we now have a situation with the funds changing. We have a time for us to revisit and to really have the courage to make the necessary changes. And to me, this is an opportunity. It's an opportunity to allow the governments to lead. It's an opportunity for us to support these governments. It's an opportunity for us to look at these reports that are launched and out there and take all these lessons learned and move with it at this point. Because with the limited resources now, there's nothing more important than helping the countries drive the changes they know need to take place.
Thank you. Thank you.
Yeah, let me try to abuse this for something else, and thanking the sponsors of this event, the Saudi Health Commission, the Specialties Commission. There's one thing I heard from you which intrigued me very much, and saying you see yourself as enablers of better practice, and that you have to work into that direction. And that is something which I would call to many of the council of a very old model of regulation, now 100 years ago. Your function nowadays is not the policing anymore. Your function is look out what you can do in order to help health professionals to work better and easier in your country. That will be your role. The other things have to be done, but this has to be the first one. So thank you to you for this incentive and this direction to go.
Thank you very much. Anything?
And I think I want to sort of add to what you're saying. I think there's a huge role for us to be in solidarity with our colleagues around the world who really don't have the tools or the mentorship, the support they need. And so how do we lean into this space and say, you know, it's still a great profession to help other people, and how can we show up for them, you know, in the field, through conferences, through helping people get professional development, and even in this time of scarcity, I think there's a lot we can do to stand beside the health workers and keep them in the game.
Thank you very much. And Jim?
Andrew, thanks. 3 points, if I may. Firstly, just to build on what colleagues have said, that's, we've seen the opportunity. There's an opportunity, a unique opportunity, which has come around through the consequences. We need to have a decolonization of global health. We need to have adult conversations. And again, so for the Saudi Commission for Health Specialties, I had the pleasure of an invitation from them earlier this year. This is not replacing the absence of one hegemonic power with the purchasing power of the Kingdom of Saudi Arabia. This is about facilitating partnerships and conversations to do things differently. So firstly, that's the key thing, and thank you, we're appreciative. The second thing really is, as we look at the resolution that is in front of us at this World Health Assembly on accelerating action on the health and care workforce. Typical process, member states drive the conversation, they agree the consensus language, but it's not just a resolution, it is a mandate for change. It is a mandate for action, and the invitation is back to everyone. Let's go and act on that. And the third thing I'd just like to say, we're talking about the workforce globally. Let's just remember, the numbers are changing daily, but we have looked at the impact of some of the ODA cuts worldwide, and more than 500,000 workers in our sector, in health and humanitarian sector, across the Africa, low and middle income countries, in the United States, in our government agencies, in our academia, here in Geneva, UN agencies, more than 500,000 people have lost their jobs. And I'd just like to say, we recognize the challenging times for all of you, our respect to them. That's part of our workforce that we need to be supporting and protecting as well, to get them back into work through these conversations to take action, create jobs. Thank you.
Thank you very much. So we've eaten into the lunch a little bit, but I think you'll agree it was worth it for the closing remarks, which were really, really great. So thank you for your time. Thank you for joining us, and enjoy lunch.
Well, we'll actually just have a few more closing remarks here before we do let you break for lunch, but thank you to the panelists. Thank you. That was such a great panel. We do a lot of panels here at Devex, and that one was particularly enlightening and great. Wonderful speakers, so thank you all. So just in our closing minutes here, before we do break for lunch, I'd love to bring Dina back on the stage and just hear your reflections on what was just this really rich conversation full of really good ideas and solutions, and what you would like for our audience here in the room and online to take forward after this event.
Thanks, Kate. As we conclude this dialogue, I want to thank the panelists for their expertise, their knowledge. I want to thank all of the audience for being here today with us. I thank our partners at Devex. The shared commitment in building a global health workforce that is ready, committed, equipped, empowered. We have a lot of challenges ahead. So it gives us great pleasure to work alongside our global community to work together towards this. For the Kingdom of Saudi Arabia, through the Saudi Commission for Health Specialties, we are eager to share our experiences. Whether it's through working on competency-based training, our digital platforms that we invested a lot in, innovative workforce planning tools. We are here to learn, to exchange best practices, and to build partnerships that are mutual and collaborative. Ultimately, investing in the health workforce is not just an economic or a technical imperative. It's a moral one. It's about ensuring that every patient in every community has access to a skilled, compassionate, and well-supported health professionals. And with that, I would like to thank you all and thank Devex.
Yes, and thank you so much to the Saudi Commission for Health Specialties for being our partner on what is such an important conversation. So we're really happy to be able to bring this to WHA here and online. We do have a lunch break now, and so we invite you to join us and continue this conversation. It'll be in the Cafe Mezzo, which is just around the corner, but several colleagues there will help guide you and show you how to get there. We will actually be back in this room at 1:30, where we'll be continuing a conversation on the impacts of the U.S. fallout that was mentioned on the stage of pullback from foreign aid and how organizations are responding. And then we will do actually our first ever for a live podcast recording. So I'm not sure if you subscribe to This Week in Global Development, our weekly podcast. So this is my plug. But we'll be doing a live taping of that here on stage. So welcome you to join us for lunch and then back here in the room at 1:30. So thank you all and thank you.